Hey guys, welcome back for another episode of 5 Minute EMS Review, where we give you short and to the point videos on different EMS topics. Today, we're getting back into EMS pharmacology with the medication atropine. We're really pushing the limits of the 5 minute review time frame today, so let's get right at it and get started. All right, guys, so atropine is classified as a parasympatholytic. Let's remind ourselves that parasympatholytic breaks down to referring about the parasympathetic nervous system, with lytic referring to blocking. So we are with atropine trying to block the effects of the parasympathetic nervous system. You may also see it classified as an anti-cholinergic because of its effects at blocking acetylcholine. Now, this medication is derived from the Atropa belladonna, which is a plant also known as the Deadly Nightshade. That's where we get our name from, the Atropa belladonna. Its mechanism of action is to selectively block muscarinic receptors of the parasympathetic nervous system, thereby inhibiting acetylcholine from causing parasympathetic stimulation. So we are trying to block the parasympathetic nervous system. Now, when it comes to the heart specifically, that occurs through the blocking of the effects of the vagus nerve on the SA and AV nodes. The vagus nerve stimulating the SA and AV nodes can slow down the rate of impulses from the SA node and slow down the speed of conduction through the AV node. When we give atropine, we're looking to block those effects. Now, you may see it indicated for rapid sequence intubation as a pre-medication to prevent bradycardia, but typically the main areas where we're seeing this drug is for symptomatic bradycardia and organophosphate poisoning. So let's talk about symptomatic bradycardia first. We said that we're trying to block the effects of the parasympathetic stimulation at the SA and AV node via the vagus nerve. And by doing that, we're hoping to speed the heart rate back up so that the SA node is firing faster and speed the conduction through the AV node. So this medication should be used on bradycardia rhythms that are originating at or above the AV node. Now, with the 2020 American Heart Association update, they upped the dose. It is now 1 milligram as your initial dose, repeating every 3 to 5 minutes up to a total of 3 milligrams total. Now, as always, make sure you follow your local protocol, but that is the AHA recommendation. One thing to keep in mind is that you should be very cautious about using it in the setting of a myocardial infarction, because the increased rate can cause an increased workload on the heart and increased oxygen demand, which can be bad in the setting of a heart attack. So transcutaneous pacing may be the better choice. Now, we also know that when we have very poor perfusion, bradycardia that is causing very poor perfusion, we may end up performing transcutaneous pacing. So you can try atropine while you're getting the transcutaneous pacing set up, but we don't want to delay and allow the patient to be in a poor perfusion status for too long of a period of time. As of the 2015 American Heart Association Symptomatic Bradycardia protocol, either transcutaneous pacing or a vasopressor infusion is acceptable if atropine is ineffective. But in reality, in my practice, I've often seen where if we are really in the tank with our vital signs, we might be going right to that transcutaneous pacing. So use your clinical judgment there, but also be aware of what the AHA is recommending, again, as well as your local protocols. Let's talk about some blocks. I've had a lot of confusion about whether or not atropine works for blocks. It is acceptable to give it for a first-degree AV block and a second-degree type 1. Second-degree type 1 may be caused by increased vagal stimulation. So if we can give atropine and block that vagal stimulation, we might see some improvement. Now, with second-degree type 2 and third-degree blocks, the AHA says that atropine should not be relied upon. Not 100% contraindicated, but should not be relied upon. Second-degree type 2 blocks indicate a problem at the level of the bundle of His or the bundle branches, which are below the AV node. Since atropine works at the SA and AV nodes, problems below that probably not going to see any response to the atropine. And then in the third degree block, we've got complete dissociation between the atria and the ventricles. And so again, we're probably not going to see any response to the atropine. One final thought, don't use atropine in the cardiac transplant patient because their vagus nerve has been cut during the transplant, and using atropine can actually cause paradoxical bradycardia. Now let's talk real quick about organophosphate poisoning before we wrap up. Organophosphate poisoning causes a buildup of acetylcholine due to the blocking of the enzyme that breaks acetylcholine down. So in the setting of organophosphate poisoning, we've got too much acetylcholine. What can we do? We can give atropine to block the effects of the acetylcholine. Now, signs and symptoms of organophosphate poisoning, your classic sludge memory aid or dumbbells memory aid. Sludge, salivation, lacrimation, urination, defecation, GI distress, and emesis. Dumbbells, diarrhea, urination, meiosis, which is pinpoint pupils, bradycardia, bronchorrhea, which is excess mucus in the lungs, emesis, lacrimation, and salivation. Those are your classic signs and symptoms of an organophosphate overdose. And those are the symptoms that we are trying to relieve with atropine by blocking the parasympathetic nervous system. Now, in organophosphate poisonings, you're probably going to require a much larger dose of atropine than you would normally be giving in a bradycardia setting. So know your local protocol and be prepared to give higher doses. All right, this drug can be given IV, IO, and you may see it given through the endotracheal tube at 2 times the normal dose. In addition, there might be an intramuscular auto-injector available for organophosphate overdose, depending on how you are supplied your medications. Side effects are blurred vision, dry mouth, dilated pupils, confusion, and as we've said already, that increased oxygen demand on the heart that you want to be careful about. So that's a quick rundown. We pushed the envelope with our 5 minutes here today, but hopefully you'll give me a little bit of grace. If you guys are new to our channel, we would love it if you would share with any of your friends or colleagues who might find it interesting. If you've been following us for some time and haven't subscribed yet, we'd love it if you'd hit that button, send us a message, and we'd be glad to say a thank you for joining us. That's it for today. Join us next time for our next 5-minute EMS review.